This is SSN.
Story Studio Network.
I'm Tom Hoppy, and I'm your host of the Most Painful Podcast. On our last episode, we spoke to Renasa Das about the impacts of brain fog. What is brain fog? What's available to help manage brain fog? So if you missed it, you can listen to it on our Spotify and Apple podcast. So many people suffer from chronic pain, and they feel that it's a very lonely journey. They feel that someone may not understand what they're going through. Well, what happens if your family doctor doesn't understand or believe you? To talk to us about it today, I'm joined by Dr. Andrea Furlan, a pain specialist in Toronto and the author of The 8 Ways to Conquer Chronic Pain. And you can listen to her talk about that on our Season 4. So Andrea, welcome to the show. Thank you, Tom, for inviting me again. Yeah, it's great to have you on. I enjoyed the last show. I enjoyed your book. I really liked the way it was laid out. And I have to say that because, I've read other books, but I really like the way this was laid out. And especially so highlighting important points. So today, I thought this is an interesting topic. And we talked a little, I read your email and we talked offline that I've also run into people who say, my doctor doesn't understand what I'm going through. So I thought maybe you could tell us a little bit about this and is it happening a lot and what can be done about it?
Yeah, unfortunately, it's happening a lot. And I think it is a reflection of the advancement in the science of pain that it's really hard to catch up. And Tom, I do this. My full-time job is to be a scientist, a professor of medicine, and a researcher in the area of chronic pain. And I do this for 31 years. And I can tell you, I cannot keep up with all the publications, the conferences, the science, the lectures. Every time I read something, it just opens the door for something else that I had no idea that I need to know. I did not know that I did not know. So it is overwhelming for me, and I can't imagine how overwhelming this is for family doctors, nurse practitioners, physician assistants, general practitioners, and these are the professionals. The majority of patients with chronic pain, at least in Canada, are seen by those professionals. They don't have access to a pain specialist like myself. The wait list is huge, and I can see them for maybe one visit, a few follow-ups, and that's it. I can't keep them forever. So they need to keep seeing their practitioners. And the other problem is not just the science is accumulating a lot, is because pain is invisible. And whatever the patient tells you that they have is what they're feeling. And because they can move well, they can laugh, they can make a joke, they can drive a car, they can look normal, these professionals kind of doubt if they're really feeling pain. And when we use those tools, questionnaires, scales, 0 to 10, and the person says, I'm in 9 out of 10, and the healthcare professional, the doctor, looks at them and says, you really don't look like a 9. So then creates that doubt, their problem, and then that tension between them. And then the dialogue really goes down the drain because it's really hard to have a dialogue when you're not talking the same language.
Yeah, and I'd like to do a deeper dive in that, but I understand the science, like you said, is hard, and or there's always something new coming out. But at the root of it when people are going through medical school, are they taught about chronic pain and some of the services that are available? Does it start there?
So yeah, it starts there in medical school, in family medicine training, in residencies. They are taught about pain, but mostly acute pain. And we know chronic pain is very different from acute pain. It's a different disease. Acute pain is usually nociceptive. I think we talked about this last time. Nociceptive means there is a fracture, there is a inflammation, there is a cut, there is an injury there. And then that heals. There might be also neuropathic pain, that one of the nerves or the spinal cord is injured or damaged, and there is a lesion there that you can see. So those two types of pain, nociceptive and neuropathic, the doctors can see because they can examine, they can do an electromyography nerve conduction study and detect that there is a nerve problem, or an MRI of the spinal cord and say, okay, you had a spinal cord injury. The problem is when those two things, nociceptive and neuropathic pain, they heal. They take time to heal. Nerves take about 6 months. A wound is usually healed, like a wound becomes a scar in about a few weeks, but they heal. The problem is when the pain persists beyond that expected time of healing, it's because now it has transformed into a centralized pain. So now the person has central sensitization, brain reorganization, a lot of fear avoidance behaviors, and now the chronic pain becomes nociplastic. That's the third mechanism. That's when you don't find anything like an inflammation or a nerve damage. It's gone, but the person is feeling pain all the time. And that is the pain that becomes invisible, and that is the pain that is not taught in medical school, family medicine residency. So they are taught usually nociceptive and neuropathic pain, but those are more acute pain. The mechanism of nociplastic pain, which is more than 90% of all chronic pain, is almost absent in medical school or residency.
So that then makes it, I guess, when we look at communication, the patient themselves doesn't even understand it. And then you have a family doctor, of course, they're very busy. And now, like you said, the patient presents like they're not in pain, but their scores indicate that they are. And then so seems to be that gap in knowledge there. So what's a way that, I guess one way is for a patient to increase their knowledge about chronic pain the best they could, like reading your book or looking on the website or something like that, and then trying to explain that to the family doctor. Have you had patients who've been in that situation, who've gained some knowledge and are still having challenges with family doctors, like having that communication?
Yes, always. Yeah, they do have, and when they are my patients, and I provide like pain science education, neuroscience. I tell them to watch my videos on my channel. I have a lot of videos that talk about the science of pain. I need to do a few more. So they become more understanding, and they become more, they understand now, oh yeah, I have central sensitization, and I can show them in the physical exam that they have central sensitization. So they become excited that now, they have something to show. And then they go to their doctors and they still don't have that good communication. I try to send on my notes, the notes that I send back to the family doctors, I try to educate them a little bit. I say, I told the patient to do this and to watch that video, to go on this website. By the way, there are excellent websites and sources of information in Canada. One of them is put by Canada. It's from Pain Canada. They have a website across Canada, and they have a lot of resources there. The other one is from Ontario, is the Power Over Pain portal, but it's also available all over Canada, where this new science is being translated to lay language. And what is most important, Tom, you know what I find? Is that peers are educating other patients. So once they understand those concepts of pain neuroscience, they are the ones who are leading small groups. They are the ones who are teaching. I even bring them to my lectures. When I have to teach family doctors, I bring patients to teach with me, because there's nothing like hearing from someone who has pain and understands what it is, and it's getting better by managing that kind of nociplastic pain, which is manageable. The good news is that nociplastic pain is mostly reversible. if it took 5 years for you to develop those new synapses, those new connections in the pain system, it may take some time. You have to be patient with yourself, but they are reversible. Those synapses can be undone, they can be unlearned, and the person will feel so much better.
Yeah, and I mean, I agree with you. We see that with our Alpine Challenge, where we are educating our veterans, and then they are becoming peers, and they are now hopefully passing that on and learning to self-manage. So I see the power in that, which is huge. And I think even when I've talked to other people, even within my own family, they don't even understand what a pain clinic is, or even know what a pain clinic or exists. So they're going to their doctor saying, I'm in pain, and it leads wherever it leads, but they don't. So I think the knowledge is important. But when someone hasn't even seen you yet, how can they advocate for themselves? Really, to if their doctor is not believing them, like we talked about earlier, what are some ways that they could advocate for themselves?
Yeah, so I would say ask the doctor who is examining you, your family doctor, your primary care provider, if they would be interested in learning more about this condition, or even to present their cases at an echo session. I don't know if I told you about this, Tom, but in Ontario, many provinces, Quebec, they have in French and English. In Ontario, we have 3 different echo programs. I'll tell you, I don't know if I told you before about the echo program.
Maybe we can refresh
Okay.
not even just me, but just refresh the audience too.
We have in Saskatchewan, Alberta, and BC. So these are professionals like me that I come with my interprofessional pain team. It's not just me. I have me and another 9 professionals. And we sit in front of a Zoom camera every single week. I've been doing this for 10 years. And then we invite primary care providers from anywhere in Ontario to present their cases. So they register to the program, and then they attend a session, and we discuss their cases for about an hour. Like, it's not just me and my team discussing the case, but it's the whole community discussing that case. Every session we have about between 50, 70, sometimes 100 professionals who are there watching the presentation and who are discussing cases. And this could be physiotherapists, nurses, social workers, psychologists, doctors, anyone from the community. We do this in Ontario, but as I said, there are professionals all over and hubs of experts all over Canada. So maybe if they want to advocate for themselves, ask the doctor if they had heard about nociplastic pain, and maybe ask your doctor saying, do you think I may have nociplastic pain? And the doctor will say, well, I never heard about that. And then you can say, well, would you like to connect with an echo hub and present my case? Would you like me to provide you with some information about nociplastic pain? Because I heard about this term. I don't know if I have this. Maybe I have this condition. And if I have, I'd like to know more how to treat this.
Yeah, because I mean, I'm sure you've probably heard about it too, where people are going on the internet, then going to see their doctor and telling them what they've read and learned and how it is. And so the approach is important, I guess, too, is by using another means like the echo group. If I said that correctly, is it the echo group?
Yeah, it's the echo group. It's CHO, and it's only open for healthcare professionals. And they could go to echoontario.ca, and then they can have a list of all echo groups available in Ontario. And then the other provinces, they can also find out the links where is an echo group, echo hub in their province. Yeah.
So, I mean, I think that's a really good idea, because then you're asking the doctor to hopefully follow through, and hopefully they have the time to follow through. I mean, they are busy and they have lots going on, but hopefully they have the time to do that. Any other suggestions or other ways that when a person is not being believed about their pain, what else would you suggest they could do?
Yeah, so I had patients that they bought my book and they gave as a gift to their doctors, and they said, "Okay, here is what I think you should read." But also, I think keeping that communication open, and it really comes the situation becomes more critical when the subject is opioids, because I think I need to touch on that because a lot of people, including clinicians and a lot of patients, they will say, why my doctor is not prescribing me that strong painkiller? Why my doctor is not giving me that pill? I will not get addicted. I don't have an addictive personality. And I'm here suffering and they don't prescribe this to me. And they think it's because the doctor is afraid of the college, or the guidelines told to the doctors that they can't prescribe opioids, or there is an opioid crisis, but I'm not the one who caused the crisis, so I should pay the price. So all of those thoughts come into mind. And I have to say that if the main cause of pain, the chronic pain, we talk about chronic pain, is nociplastic pain, that physician or prescriber should not prescribe opioids, because the pain alarm system, the nociplastic pain means that the alarm system, which is the pain system, is already malfunctioning. And we know if you put opioids in this body, you're going to put gasoline on the fire. And those abnormalities, those neuroplasticities will become even more abnormal. So that's why it's so important to know what is the mechanism of pain that I'm treating. Now, if the chronic pain is mostly caused by nociceptive or neuropathic components, then opioids could be tried in a trial and see if that helps the quality of life of the person. So that's why it's so important to understand the neuroscience. What am I treating exactly? I'm not treating low back pain. I'm treating what kind of mechanism. Is this low back pain because it's nociceptive? I don't see any inflammation. There's nothing inflamed here. There's nothing broken. There's no infection. And so there's no nociceptive. Is there a nerve? There is a nerve damage causing nerve constantly in that spine? That's neuropathic. But low back pain, tongue and neck pain, spinal pain, more than 90% are nociplastic when they prolong more than 3 or 6 months.
Yeah. So what you're saying is basically, in layman's term, long-term pain, depending on where it is, having opioids will not help.
Will not help in the long term. That's the problem, because initially when they take that first few pills, they will feel better. And that's the problem. The pill is so tricky because they will feel their pain better initially in the first few days that they take. But if they keep taking it, the body develops tolerance and dependence. It stops acting. And then if you keep putting that in the body, it activates some receptors that cause more central sensitization. So it will spread the pain. It will make the pain more intense.
This is part of the education for the patients themselves, is to really understand why they may not be getting, like you said, getting prescribed the opioid for that. And then on top of that, hopefully their primary care clinician will send them to someone like you so they get a better understanding of it.
So we tell them if they need to prescribe opioids because there's an acute flare-up, let's say that they had a surgery or they had a fall and they hurt their back, prescribe for a short time, like 3 to 5 days, and then stop, so then they don't develop those complications. But you understand how that conversation becomes uncomfortable, because the patient, the person is in pain and they want something to alleviate pain. And maybe they tried an opioid because the dentist maybe prescribed for a toothache. And then they say, well, but I took that Percocet for my tooth and then my back pain resolved. Why the doctor is not giving that to me? So that conversation needs to happen. But sometimes they don't have time for that conversation.
Well, and then we also put in mental health with pain. And then depending how desperate the person is too, if they've been struggling with it for a long time, then they may not be able to communicate, how would I say, probably in a better frame of mind than someone who doesn't have mental health on top of chronic pain.
Absolutely, especially because we know low mood, anxiety are so prevalent in our population with chronic pain. And also because it's part of the nerve system malfunctioning. Those neurotransmitters that regulate mood and anxiety and stress levels, they're the same ones that are involved in the neuroplasticity of nociplastic pain. So imagine if you don't have motivation, if you're anxious, you're stressed all the time, how are you going to have those conversations? And pain itself is a very strong stressor. Being in pain all the time activate all of these stress hormones, adrenaline, cortisol. They don't sleep well, they are fatigued during the day, they're insomniac at night, they don't have energy, they have the brain fog that you mentioned in the beginning. It's really hard for them to advocate for themselves. That's why I find that once they find a group, a peer group, someone who went through this and is able to help them, maybe I would say they might be the best person to take them by the hand and go on the journey with them because we don't have time to do this with them. I train these people, I help them like peers and healthcare professionals. I've been doing it for 10 years now. We train more than 1,500 professionals in Ontario, but it's still, we have a lot to go.
Yeah, and I was going to say that when you were talking before you got into the peers, it really is an important component to help somebody because especially if the peer is well knowledged and has come through the other side and is able to stand back and really provide that input and that's why with ours we also add the outdoor component because as people start walking in nature, they talk more. That's what we're finding. They're communicating more because it's more relaxed and they're in nature. So, hey, how did this work for you? Did you read this book? Did you do this? And so, but then hopefully that discussion then carries into the doctor's office. But from what I'm hearing you say is what if they have more knowledge, which is then when they walk into the doctor's office, that 15 minutes they have could be used very effectively.
Yeah. I would say I'd like to end this, Ton, with a message that pain science knowledge is the first step in the therapy for chronic pain. Both sides, for the clinician, for the patient, both sides of the table, they do need to improve pain knowledge. When I get a patient in front of me and I ask them, how much do you know about your pain? How much do you know about fibromyalgia? How much do you know about sensitization? And they say nothing, or, oh, I know fibromyalgia is pain all over the body. I say, what else? No, nothing else. And then I say, well, if you were diagnosed with a disease, like one of those big names diseases or diabetes, wouldn't you try to learn everything about that disease? Why you're not interested in learning everything about this condition? There's so much for you to learn. That's the first step. Education, knowledge is part of your therapy. And I tell my patients, you need to know more than I do. You need to come here next time and teach me about your condition. I'm going to ask you. Maybe that's why sometimes they don't come back for follow-up because they didn't do their homework. But I say, I'm going to ask you questions. You need to know what is this that you have because I will need to use that to help you with the therapy's interventions that I need to suggest to you.
Yeah, and I'm fully agree with that and I buy into it. I mean, every time I talk to a guest, I learn something new. I mean, that's one of the reasons we did this podcast because people's lives are very busy and we live in a world of social media where it's a 6-second news story. And so by having short bites of information like we're doing here today, at least that starts the path and they get the kind of key points I would suggest and hopefully they get interested and learn more. So I agree with you. Knowledge is power.
Yeah.
It really, I've seen it with my own eyes. I've been through it myself, and I think it is key to helping people.
Yeah, and thank you for doing this because you are filling a gap that is so much needed.
Well, thank you, and having people like you on really makes it worthwhile because without that we wouldn't have any show. So I appreciate that. So, any final 10-second tips that you have that you would add, that we didn't cover today to help somebody who's maybe not communicating with their doctor or vice versa?
I would just say, don't lose your hope. Get the knowledge that you need about your condition, and tell your healthcare provider also to learn, because it is a difficult field. It's a complex condition. It's not easy to get all this knowledge, but there are a lot of science about chronic pain that we know now that we didn't have no idea maybe 20, 30 years ago.
Yeah. Well, they can read your book or buy your book, like you said, and give it to the doctor, or they can also send the doctor our podcast as well. So thank you, Andrea, for being on. So for our next show, an interesting report came out from the Senate and Veterans Affairs as well. So, do Canadian female veterans truly face unique challenges? So that will be talked about, and it's quite interesting because there are some differences, especially with chronic pain, from what I've heard of this report, between female and male service members. So for feedback about our show or more information on chronic pain, you can visit our website at veteranschronicpain.ca or follow us on Facebook, at Twitter at chronicpaincoe, and on Instagram at chronicpain_COE. Andrea, once again, it's a pleasure to have you back. Great information today.
Thank you for inviting me. It's my pleasure.
And to our audience, stay safe and keep the hope alive.
The Most Painful Podcast
is produced for the Chronic Pain Center of Excellence by Story Studio Network.